Welcome and thank you for reviewing my project titled Procalcitonin Guided Antibiotic Therapy and Approach Considerations by Carlos Minjarez at Maryville University. Special thanks to community members DNP Project Chair Dr. Galakatos and DNP Project Advisor Dr. Morrow, without whom this project could not be possible. A little bit about myself. I obtained my Associates of Science in Nursing in 2016, subsequently returned my Bachelor's in Science in Nursing in 2017, and am projected to graduate my Doctor of Nursing Practice in December of 2021. As a nurse, I have experience in the intensive care unit and the emergency department, and as a clinical supervisor. Prior to my nursing career, I have experience as an EMT and as a hospital corpsman with the United States Navy. My personal connection to this project is that as an emergency department nurse and intensive care unit nurse, this DNP candidate personally manages and coordinates the care of patients in the midst of bacterial infection on a daily basis. However, time and time again, this DNP candidate has personally witnessed the swift and seemingly unstoppable decompensation of cardiovascular collapse caused by multi-drug resistant organisms. If the U.S.'s healthcare system hopes to stem the tide of sepsis, then all clinicians must participate in antibiotic stewardship and look towards innovative strategies that help navigate the challenging decisions therein. Less than a century ago, the advent of penicillin seemed a near decisive victory against the microbes which had been a death knell just a few years prior, yet bacteria had quickly begun to develop resistance to this novel tool. Procalcitonin-guided antibiotic therapy could provide clinicians with a novel tool for curtailing overprescribing behaviors, earlier de-escalation of antibiotic therapy, and reduced lengths of hospital stays. The purpose of this quality improvement project was to explore the efficacy of this biomarker and examine the adoption of an integrated treatment strategy. An electronic chart review was conducted to observe differences in patient outcomes through a pre- and post-intervention analysis after the integration of a procalcitonin protocol. The protocol was adopted and introduced by an acute care facility in the western region of the United States in September of 2020. The pre-intervention cohort consisted of patients admitted between January and March 1st of 2020. The post-intervention cohort consisted of patients admitted between January 1st and March 1st of 2021. This is an example of a typical procalcitonin-guided antibiotic therapy. However, this is not the one used by the facility where the project was conducted. To illustrate the severity of this problem, a recent report from the CDC showed that over 2.8 million antibiotic-resistant infections occur in the U.S. every year, and over 35,000 people die as a result. The same report showed that antibiotic use may be associated with over 223,000 Clostridium difficile cases per year, which cause the deaths of over 12,000 people. In the same report, the CDC listed 18 antibiotic-resistant bacteria which are of urgent and serious concern to the U.S. In a recent study, procalcitonin-guided antibiotic therapy, or PGAT, was associated with a reduced number of antibiotic days, a reduced inpatient length of stay, and without any significant increment of adverse outcomes or mortality. Antibiotic stewardship using a PGAT protocol could potentially preserve the efficacy of pharmaceutical antibiotic agents for decades to come. What is procalcitonin? Procalcitonin is primarily synthesized by the parafollicular cells of the thyroid. As an acute phase reactant, it can increase by up to 2 to 3 orders of magnitude in the presence of endotoxins and certain cytokines. Unlike other inflammatory markers, procalcitonin production is downregulated by the cytokines that are more specific to viral infection. The combination of these two traits make it an ideal signal for differentiating clinical presentations that are not easily distinguishable between bacterial or viral etiology. Prior to the initiation of the project, a literature review was conducted, which included several online databases of peer-reviewed published studies. The search included worldwide articles between 2014 and 2020. This rendered over 1,087 articles, the first of 100 included for consideration. 19 of these met the inclusion criteria. In this analysis, 3 themes emerged: mortality, length of hospital stay, and antibiotic exposure. In the case of mortality, 10 studies measured mortality, 3 of these found a statistically significant improvement. In length of hospital stay, 15 studies measured the length of hospital stay, and 12 of these found a statistically significant improvement. Antibiotic exposure, 15 studies measured this, and 12 of these found a statistically significant improvement. A strength identified in the evidence was that there was minimal attrition or data loss of poor follow-up, as most of the studies conducted in acute care facilities. Studies range in size from single-center studies of 50 patients to multi-center studies over 1,600 patients. The review also included meta-analyses ranging in size from 10 studies to over 26 studies. However, there were some weaknesses in the evidence. Many studies lacked blinding and randomization. The studies included also were of limited spectrum of infections and studied only those infections in which the evidence for PGAT is most robust, that is, sepsis, lower respiratory tract infection, and urinary tract infection. Lewin's change model, commonly articulated as the process of unfreezing, changing, and refreezing, was a theoretical framework for this project. Though seemingly rudimentary, Lewin's model described the essential steps in lasting change. The nuance of this model is in the opposing psychosocial forces and facilitators and barriers to change. The tension involved therein illustrates the role of leaders and learning curves. At its core, Lewin's work is an understanding that for a new behavior to be adopted, a process of remaking must take place. The specific aim to this project was to assess the clinical utility of PGAT in an acute care facility after the introduction period. This is best illustrated by the PICO question, which can be articulated as: in adult patients suspected to be in the early stages of sepsis or diagnosed with a lower respiratory tract infection, will the inclusion of PGAT when compared to standard care result in shorter hospital stays, shorter intensive care unit length of stay, shorter antibiotic courses, reduced readmission, and reduced mortality without reducing the quality of care delivered at 30 days? The first 3 primary outcomes were recognized as process-oriented outcomes, while the last 2 secondary outcomes were studied as an essential balance and recognition inherent value of patient-oriented outcomes. The method design of the project was a quasi-experimental chart review, was conducted before and after PGAT protocol implementation. The project used sequential convenience sampling, which included 100 cases. Only 46 cases would be needed to yield adequate power based on a Cohen's d calculation that was calculated based on a separate study of similar design. My inclusion criteria were adult patients admitted between the ages of 18 and 89, admitted to the inpatient hospital setting, and diagnosed with either sepsis or lower respiratory tract infection. My exclusion criteria were patients diagnosed with either dialysis-dependent renal disease, a current cancer diagnosis, immunosuppression, a thyroidectomy, or recently experienced severe traumatic injury. And that is because those are areas in which PGAT has previously shown to be less reliable. IRB approval was obtained through Maryville University. The sample included adults of ages between 18 and 89. A total of 100 samples were reviewed. No demographic data or personal identifying data was recorded for protection measures. A composition of the local community was studied based on the most current local census data. Data analysis included statistical review of primary endpoints using a MAP-MITNE-U test. That is because the data was shown to be non-parametric and the subjects were not the same group of patients despite the subjects originating from the same acute care facility. For secondary endpoints, a Fisher's exact test was used for data analysis. This is because secondary endpoints were measured as binary values, and on cross-tabulation some of the cells contained values less than 5. Displayed below are the distribution curves of all the primary endpoints. from the post and pre-intervention cohorts. In the primary endpoints of length of hospital stay, length of ICU stay, and days of antibiotic exposure, no statistically significant outcomes were observed. Among secondary endpoints, 30-day mortality and 30-day readmission, also no statistically significant outcomes were observed. Below is a box plot showing the distribution and means of all variables from the pre- and post-intervention cohorts, thus illustrating that the means were not significantly different. There was, however, an incidental finding of a correlation that was identified between both initial and final procalcitonin level and 30-day mortality. However, these results were not part of the outcomes as defined at the outset of the project. The implication of this correlation signal that procalcitonin may objectively measure severity or acuity of illness. However, the quantifiable utility of this may not be far and above the clinical gestalt of practicing providers. The limitations in this project were that PGAT protocol adherence was not measured. This would include expediency and consistency of antibiotic discontinuation. Outcomes were also not separated by medical teams, since the managing antibiotics could have been prescribed by a resident internal medicine team, an attending internal medicine team, critical care pulmonology fellows, or infectious disease specialists. The SARS-CoV-2 global pandemic could have also affected results by poorly understood mechanisms. Discordant observations between the results measured by this quality improvement project and published studies of similar design can most likely be attributed to three major confounders, the first being an unknown effect of COVID-19. As of the completion of this project, the world is in what is likely to be the tail end of the SARS-CoV-2 global pandemic, which has thus far claimed the lives of over 4 million people according to World Health Organization data. The gravity of this historical event is an ever-present reminder that continued human well-being rests on the healthcare industry's ability to deliver life-saving agents that reliably stave off microscopic invaders for decades to come. As of this time, the exact nature of the novel coronavirus has not yet been identified. However, historically, procalcitonin levels are upregulated by the presence of bacterial pathogens and are downregulated by the presence of viral pathogens. However, a study published in August of 2020 observed that procalcitonin levels were elevated commensurately with acuity of illness and in patients infected with SARS-CoV-2 pathogen. This finding by this research team would identify this specific viral infection as a profound confounder in the utility of PGAT. The second factor being the expediency of protocol adherence. Regrettably, this quality improvement project did not set out to measure this valuable metric in its design. However, there is some evidence that many providers are slow to adopt PGAT and often utilize procalcitonin levels when the diagnosis and clinical stage are unambiguous. The third factor which could have affected the results would be selection bias. Selection bias could have affected the results observed. As the quality improvement project was conducted amid the SARS-CoV-2 pandemic, emergency department providers may have consciously or unconsciously selected sicker patients for admission than whether they would have normally selected for admission prior to the pandemic. The pandemic stretched the capacity of many healthcare facilities to their limits, and this may have swayed the judgment of the admitting teams. Throughout the course of the pandemic, many hospitals employed changes to their admission criteria and had to rapidly adapt to escalating patient volumes. This could have been controlled for by observing and comparing age, vital signs, comorbidities, resuscitation efforts, and other indicators of acuity, such as lactic acid, use of vasopressors, use of ventilators, and oxygen therapy. In summary, the primary endpoints and secondary endpoints measured before and after PGAT protocol showed no statistically significant difference in outcomes. However, there were some incidental findings that were of interest. The concerns for this project was that PGAP protocol adherence was not measured, outcomes were not separated by medical team managing antibiotics, and the SARS-CoV-2 global pandemic could have affected the results by mechanisms not yet understood. After thorough review, I cannot recommend the continued broad application of PGAT given the findings of this chart review, the mixed evidence surrounding its utility, rising healthcare costs, and the apparent limited scope of applicability. Based on a broad investigation of the evidence, this quality improvement project recommends limited application of protocol in adherence with leading organizational guidelines. Guidelines from the CDC recommend the prioritization of prospective audit and feedback programs in which either stewardship, pharmacists, or infectious disease physicians review antimicrobial orders and provide recommendations to prescribers regarding optimization of antimicrobial use. The CDC also emphasized the efficacy of requiring prior authorization approval by infectious disease physicians or pharmacists before certain antimicrobial agents may be administered. Multifaceted systems that adopt high-yield strategies are becoming the mainstay of both stewardship and course reduction. In this field, PGAT may still play a role. However, the medical and nursing community must look to more reliable avenues for success. The implications for nursing practice is that shorter antibiotic courses are associated with shorter hospital stays and even improvement in certain patient outcomes, as observed by a recent Cochrane review. Infectious disease control measures may be even more consequential in the mitigation of resistance patterns, as observed by a recent large multi-center trial. Diligent application of these measures at every level of nursing impacts the care delivered to patients. Sepsis continues to be one of the most expensive diagnoses with an annual cost to the U.S. of over $60 billion. Though advances in protocol technology and supportive measures have improved outcomes, the mortality continues to be approximately 30%. Blood cultures continue to be the gold standard for diagnosis. However, the time lapse can cause dangerous delays in treatment. The integration of emerging biomarkers and guidelines can give clinicians another decision support system in the fight against sepsis. Advanced practice registered nurses are on the front lines of patient care across a great variety of practice settings, are an invaluable asset to the treatment team. By staying abreast of emerging scientific discovery, APRNs honor the call to evidence-based practice and deliver cutting-edge care that is safe, efficient, and effective. The impact of this quality improvement project has yet to be determined, as dissemination and distribution has just commenced with the facility on which the project was commenced. However, integration should commence after an internal confirmatory review of the data. In my further work, I would like to explore the clinical outcome differences between PGAT and evidence-based prescribing strategies, such as those proposed by the Infectious Disease Society of America or the American Thoracic Society. I would also like to identify specific conditions and clinical situations in which procalcitonin may be of more clinical utility. The Doctor of Nursing Practice program has illustrated the tremendous depth in the scientific underpinnings of nursing practice, the value of leadership in organizational structures that influence quality improvement, and has shown me how to more critically evaluate clinical scholarship and the analytic methods in crafting evidence-based practice. Thank you for watching my doctoral presentation. I welcome your comments and questions.